My name is Sam. I'm a musician, I'm a father, a husband, and since 2020, I've been a brain tumour patient. I'm making these films with the Tessa Jowell Foundation to help explain what it's like living with a brain tumour. I'm delighted to be sitting here and having a conversation today with Mr. Babar Vaqas. I'm going to call him a neurosurgeon, but he is so much more than that, and I will let him introduce himself. So thank you for being here with us today.
Thanks, Sam. Yep, I'm Babar Vaqas. I'm a brain surgeon, and I specialise in brain tumour surgery.
Excellent. So the whole point of getting you in today was to have a chat. I know that sounds silly, but as a brain tumour patient myself, you must see plenty of me through your doors every day. And we have been looking at the patient perspective of this whole journey. What I wanted to open up is your journey through this whole process, because there is another side that we don't see at all. If you're anything like me, I put all my reliance on my neurosurgeon, my brain surgeon, my clinical team. But I want to find out how it is for you. How is it delivering some of those really difficult messages and those conversations, and your approach, really? So I know that's quite difficult, but I think it'd be really useful for us to hear that.
Sure. For me, it's something quite close to my heart, and it's a central kind of thing. It's the essence of kind of who I am, and it kind of started at medical school.
Yep.
And during my first year at medical school, we had really long summer holidays at Oxford. So basically, you have many weeks, and most people went on holiday. But I decided to volunteer at the Royal Marsden Hospital.
Okay.
And during that summer, I was attached to a haematology oncology specialist, and for the first time in my life, I saw someone deliver very sensitive news to a child who had a form of leukemia and the family. And that doctor did it in such a way that I really appreciated the humanity with which he approached quite a technical and scientific conversation as well. And I loved that balance, and I really admired that. And for me, that is the epitome or the pinnacle of medicine, is to use your scientific knowledge, in-depth knowledge and experience, but to connect it with a human being and use it to improve someone's life in whatever way possible. And that started my journey along oncology and cancer. And that really triggered my lifelong interest in cancer and helping people with cancer. Hematology is interesting. It's very different to brain cancer in that a lot of the conditions, although they can be dangerous, are treatable.
Right.
And there's a lot of hope.
Yeah.
And I happen to have chosen a speciality with which a lot of the tumours are not curable. And so it's harder to grasp that hope. But there's always something there. If we can't add years to life, we can certainly add life to years. We can improve that quality and that path. And that's really what I wanted to do in neurosurgery. So I gravitated, once I started neurosurgery training, towards the area of neurosurgery which involves a lot of communication, a lot of sensitivity, and neuro-oncology or brain tumours was that specialisation for me. So that's how I, that's the crux of why I fell into it, really.
Yeah, absolutely. And I guess one thing I'm interested to know, when you meet patients and you have to deliver those conversations, is it a kind of one-size-fits-all approach that you take to kind of detach yourself away from emotion, or is it about understanding the patient, or I'd love to know what your approach is when I'm delivering that kind of news, and how you build a relationship from there?
It's a really good question. It is never a one-size-fits-all approach. What I find is a very personal approach, depending on the doctor. The way I approach it is very much as a personal conversation. Not with a patient, but with a colleague or a friend. And in a way, I'm an advocate for them, because I've got certain knowledge that they don't have, but they are the person that has to walk through that path that I'm attempting to lay out in front of them. And so, although there are certain set things I do to prepare for breaking bad news, and which will be done in every centre. Things like, for example, identifying a safe space, identifying a good colleague to see that patient with, finding out in advance who's going to be with the patient so I can mentally prepare. There's a lot of things we can do.
So just to go back to that, you try and deliver that news, all those difficult conversations with someone alongside you.
We always try to have someone there. It could be a clinical nurse specialist, or it could be a doctor or medical colleague who's involved in care. So we do it together. It helps because it's such a deep thing to do. Doing it on your own is actually quite frightening on the medical side, particularly if you're going to be dealing with lots of emotions. And the other thing is that after being through that, doctors do feel it. I certainly feel it. And I want someone to talk to after I deliver that bad news, because you kind of wonder, could I have done it differently? Or were there certain questions that I didn't answer as well as I could have done? And having a colleague there with you really helps. Helps share that moment. Otherwise, you keep that moment to yourself. And it's really stressful, and it accumulates over time. So we really try to make sure there's space, emotional space, on the medical side, on the doctor's side, with a colleague to share that experience, and at the end of the day, to make us better at delivering that. Because I don't think it's something which anyone looks forward to, but when it's done successfully, you help the patient along the next phase of their journey. So there is some degree of positive progression in some way. And that's what we try to achieve, and connect with the patient in that.
That's so reassuring to hear that. And it's really interesting that you take in another one of your colleagues, because I guess you have to share that burden as well. Just the way we build community as brain cancer patients within each other, I guess that's the side that you need to. I mean, I think sometimes, like when I first started this journey, neurosurgeon must be a very brainy individual, very clever individual. Just do your job, get out of there, detach yourself from everything. But to hear that that's not the case, and I know everyone is slightly different, but it's reassuring from our side because you know us personally. Even when I first met you, without going with the Mr. and the very formal kind of titles that go with that, just being able to have a conversation almost like with a friend I loved it. And I just, from my point of view as a patient to you, that's so important. Like you said,
I think you can feel it in the conversation with your patients. It's the humanity that drives my intellectual rigor. So that is the fuel that drives the need to know about the genes, about what treatment to give. Otherwise, there'd be no, it's just an intellectual exercise and nothing. And when you form that connection and that authenticity, the patient feels it and the family feel it. And that's the start of, in essence, what is a partnership. Because I can't do what I do without my patients, and my patients can't do it without me. And you do form this really strong bond. And it goes beyond just delivering care. So I've been to the funerals of my patients that have passed away. I'm still in touch with those families. And we're still trying to, through the Tessa Jowell mission, try to make things better for everybody. And I think you become part of this community. You really do, of patients, medical professionals, allied healthcare professionals as well. And it really affects us. When a patient passed away not too long ago, both myself and the therapists and the clinical nurse specialists, we all had to meet each other because it impacted us. And you can't, every patient affects us, but you find certain patients and families and their stories will affect you in unexpected ways. And that's what we found in this particular case. There was something about it that made us all feel, we need to talk to each other, we need to meet, and we need to share our thoughts and our experiences of what happened. It was an exceptional person. But what I see, it's really weird. I feel so privileged that I'm able to see such crucial moments in people's lives. As a doctor, it's a window into your own mortality, into the fact that, hang on a minute, what's important for me? So there are evenings when I go home and I will hug my kids, and I will value my mum, and I will give my sister a ring, because my experience that day has shown me how fragile life can be and how important it is to connect with those. And what's the true meaning of life? It's the people around you.
That's just it. Because I didn't expect you to say that, because as a cancer patient, when you hear those words, brain tumor, cancer, you've got this flush, this filter of what's important in life and your priorities, and the things that you were chasing after, you realize what was just a waste of time and not important, and living now, what is important. And I guess, like you said, picking up the phone to your sister, it's those simple things that you always think that you can do that all of a sudden become like, no, I need to do that now, not wait till tomorrow. And it's really, for me, inspiring to actually hear you say that, because that is our journey kind of on a day-to-day basis as a patient. And to hear, not in a bad way, like, oh, you suffer too or anything like that, but to hear that emotion that you feel is it's eye-opening for me, to be perfectly honest with you, because we don't get to see that side of it. It's kind of like our appointment.
And doctors won't share it with their patients. So, because you've got to do your appointment and you've got to
be this big.
You've got to give that structure to things when things are falling apart. You've got to be the foundation. And this is probably the first time I've shared this kind of experience in public.
I appreciate that.
Because it's the kind of thing that my family know.
Yeah.
My mum or my sister will know. But it's the kind of thing that we don't. But I think it's important to get it out there that this is the fuel that drives people like me. And my colleagues, who, I mean, I'm not unique. My colleagues share this love of life and wanting to improve the quality of life for everybody. But it really focuses you. And in a strange way, I'm thankful to my choice of speciality, that it gives me this perspective on life that I may not have had.
Yeah.
You tend to be slightly less materialistically driven. Mm-hmm. More value driven,
and
I think that is it's really philosophical. So
it's a whole different conversation.
It's a different conversation. It's for a different time. But these encounters do tell you that life is fragile, and it takes very little to But also it allows me to focus in on when patients are anxious or frightened or confused. It gives me the emotional ability and the space with which to gently approach these topics. And to acknowledge them, and then to talk through those options. Because it's often very, very frightening when you tell someone that, and often they've been totally well beforehand, because brain cancer tends to affect people out of the blue.
It creeps up on you.
It just creeps up on you, and you will get this hand on your shoulder out of nowhere, and all of a sudden you've got all these things to worry about. And that is something which I really find quite causes a lot of anxiety, fear, and confusion. But also the pathway is so complicated, and navigating through it adds on more worries to the patient and family. And that's somewhere where I feel I can help. I can describe the pathway to them and the options available. And that's where I really feel I can make a contribution and bring some clarity to the situation. But it's frightening. Often brain tumours grow so quickly that your symptoms develop rapidly. So it's a very worrying time when out of nowhere you may have a headache, you may have had seizures, you've got a weakness somewhere out of the blue, and things are just changing all the time. And the other added problem is that you may have had a scan, but an MRI is not a diagnosis. It's just the starting point. And then you've got this uncertain time ahead of you. So it really is an emotional roller coaster that you start, and it's quite a thing. So it's a challenge, but I wouldn't change it for anything. I really feel like I'm able to make a difference to people's lives with what we do. Yeah,
you are making difference. One thing I'm really keen to kind of help people with that are just starting this journey is that journey pathway. And I'd love if you could kind of, from your own experience, I know every patient is completely different, but kind of almost like a typical pathway through this, from the initial diagnosis and through that journey. How do we do that on a practical day-to-day basis?
Sure. And these pathways will vary slightly depending on where you live, but certain core elements will be the same. So most patients with a brain tumour or with an aggressive brain tumour will present through an emergency route, so through accident and emergency, and a scan would have been done to show some kind of mass in the brain. So at that stage, most what'll happen, so that people know what goes on behind the scenes as well, the A&E department will then contact their local neurosurgery centre,
Right.
where there'll be an on-call neurosurgery service,
Right.
24 hours a day. And there there'll be a registrar and a consultant on call that will take the referral, and they will decide whether immediate surgery is needed as an emergency, or whether we can discuss the case at a larger meeting. We call it a multidisciplinary meeting,
Right.
and a more detailed plan can be made for that particular person. So normally we do MDT meetings once a week. They will have a range of consultants present from different specialities, as well as people who are clinical nurse specialists, therapists, specialists in palliative care, lots of different areas, and consultant radiologists as well. And the case will be discussed in detail, in depth. Often some kind of plan will be formed as to what to do next, and the patient will be seen very soon. In the centre where I work, we have a multidisciplinary clinic as well.
Right.
So that same week we will see those patients in that clinic.
Okay.
So there's quite a rapid, things move pretty quickly, actually.
Okay, yeah, I was going to say, yeah.
And that will be the first time the patient will see a surgeon. We normally recommend that people don't come alone, because there'll be a lot of information given. So come with someone you trust.
Yeah, yes.
As you could probably, from your own experience, you'll know that there's a lot of information that will be delivered in that session. And in that session, we will typically go through the scans, talk about possible diagnoses and what could be going on, and our plan moving forward.
Okay.
In most young people who are well, where the tumour could be technically removed, and if it looks aggressive, but technically removable, we may suggest that we do surgery, and that we will go through in depth as to what that means at that meeting. So normally we will go through the benefits, the risks, and also the alternatives as well to the surgery. And if surgery is needed, we will then schedule that to happen quite soon afterwards.
Right.
So the system is quite quick, actually, for dangerous tumours, and is designed to be agile and move quickly.
Right.
But it does mean there's a lot of information given to patients and the families, and decisions have to be made fairly quickly.
Okay.
Often the decisions would be, do we biopsy or do we actually try to remove the tumour?
Before you do it, just go straight in for it. Okay.
And it's different to other types of... So patients may have experience of other types of cancers,
Right.
Or relatives will as well, where biopsying is possible before you do a bigger operation.
Yeah.
But brain cancer, unfortunately, is the other way around. Often we have to remove a lot of the tissue at the first sitting.
Right.
And then we'll have the diagnosis confirmed once the tissue is analysed in the laboratory. So that's something which sometimes people, we kind of help, people get their head around that concept. We do still sometimes do a biopsy as well, if we're very uncertain as to what something might be, or if a tumour may be too dangerous to attempt a larger operation on, but we still need to know what it is, we may recommend a biopsy. So we still do biopsies. And the other strange thing about brain cancer in general, although there are a couple of tumours that are more common, there's a huge range of other possibilities that are rarer.
Yeah.
And again, juggling that in that shortened clinic environment is quite difficult. There are over 100 or 140 types of brain tumour.
Wow. So I didn't even know it was that.
There are a lot, yeah. And the rarer ones are many, whereas the commonest ones are not very many. So, but you still have to encompass all the possibilities when you meet patients in clinic. So that makes the job quite challenging.
Yeah.
So that's a typical pathway from A&E presentation to surgery.
And that's typically the pathway. It will come out of the blue. I mean, everything you explained there is pretty much my pathway. Came out of the blue when I was sat on the train, admitted to A&E, came up in a scan. Luckily for me, I was at a neurospecialist hospital anyway, so I got through that system quite quickly. But like you said, all those conversations, the importance of having someone with you to take that information, because there's only a few words I picked up on, and you're only looking for like life expectancy and those kind of bits and pieces where what's the next step, like practical step, but the rest of it just kind of goes whoosh, right past you.
Much. Yeah, because day one you're a normal human being, and then all of a sudden this has happened, and it's a whirlwind, isn't it?
And like you said, those steps have in certain cases have to happen very quickly, almost immediately in some certain cases. And then you have other cases, wait and watch, which is kind of what I went under as well. But generally speaking, in that first appointment, without knowing too much more, i.e. a biopsy, you set that pathway in that meeting. And kind of this is what we follow until kind of as we get more information, that may change.
It's still a time of great uncertainty, because that first meeting, you still can't give a definitive diagnosis, which is what everyone wants to know.
Yes,
like,
absolutely.
What is going on with me? You know, what kind of tumour is it? And that's what I can't definitively say.
Right.
I can say we're suspecting it might be. That's why we're doing things quickly, because it could be something nasty potentially. But that's a very, very difficult. That uncertainty, unfortunately, doesn't get solved until the tissue's been removed from the brain, it's been analysed in the laboratory, and we've then discussed it in a further multidisciplinary meeting, and then we've confirmed the diagnosis. So that certainty, unfortunately, doesn't happen for many weeks. And it's difficult. It's a very difficult time for the family and for the patient, because what if the tumour grows further unexpectedly during that time frame, or something happens, seizures go out of control. There's lots of things that could happen. But we try and set up a system with safety nets so that there's a contact with our clinical nurse specialist. They know now that the care is going to be delivered at their regional centre, so they know where the care is going to be. So if unfortunately, and it doesn't always get worse, and patients are often fine as they wait for surgery, but if something does happen untoward, there is a safety net there where they can be seen very quickly.
Right.
That's also quite important. So giving that structure at a time where uncertainty continues is a big challenge, but it's something which we try and do. And to say that you're not on your own. You've got a surgeon, you've got a clinical nurse specialist, you've got allied healthcare professionals. So in our centre, we do a prehabilitation review as well. So very soon after that surgical appointment, there will be a further prehabilitation appointment where we will look at lifestyle factors and optimise things as much as we can.
Right. Okay.
So what you'll find is if things do go over your head, there are multiple points where you'll have continual contact with us prior to surgery where you can get further information.
Right.
And every individual's got their different way of accepting information.
Right.
And also the rates of information. You've got to have, it's quite a skill to give the right amount of information at the right time.
Absolutely.
It's a bit like a bucket, or if you overfill, and it's already full now with all the worries of having the tumour. So now I'm adding to it with,
bring a second bucket.
Second bucket. You need another brain. You need another, That's what's difficult about this situation. Yeah.
I found with my relationship as well with my neurosurgeon, he understood me very quickly, and he understood my wife very quickly, because as she's a GP, she wants the technical detail. I don't want any of the technical detail. I need basic, you need to put it in layman's terms to me. Yeah. And he quickly understood that. We developed a relationship of mate, hey mate, how you doing? And very different to how my wife dealt with that. But he understood that very quickly. Yeah. And I think that's kind of, it was really important for us in building trust, like you were saying before, because from what I'm understanding, from what you've said, that you are almost like the first decision makers in the journey almost, because as soon as you hear the words brain tumor off of a scan, it will be referred to yourself. Is that correct? Yeah.
So surgeons are in the UK and also I think globally, neurosurgeons will be at the start of the pathway, because you can't go down a treatment route without knowing the diagnosis.
Right. Okay.
And the diagnosis, I would say, almost always requires surgery. Okay. A formal diagnosis. So surgeons are the first and foremost. Whereas in other kinds of cancer, surgeons appear later on down the road.
That's really interesting to know that, because, and it was interesting to hear what you said about you can't give a definitive diagnosis and say it is X, Y, and Z at that first meeting as well.
You can't. Yeah. You'll have a educated estimate and suspicion, but you can never be 100% definitive or definitive enough to give treatment that could be toxic. So chemotherapy or radiotherapy, you need to know for sure that you've got the said cancer before that kind of quite extreme treatment. Although it's really well tolerated in the vast majority of cases, you still need to have that high level of certainty. Yeah. And that's what you don't have at that first meeting, which is an issue.
And I think that's really important for people to know almost, because yeah, I remember going into that first meeting thinking, right, I'm going to know everything after this. I'm going to know exactly what this is, how long I've got to live with it, what we're going to do treatment. And actually what came out of that is there's a lot of question marks around a lot of different things.
That's right.
And you've got to almost play it every day. Like
Absolutely.
I say it like a game, but yeah, it's a battle every single day.
I think you take every day as it comes, and with all the challenges, because there's a lot. The other thing to mention is that as you progress through the pathway, the certainty solidifies, and we'll get more information. Not only when it comes to diagnosis, but your response to the treatment. Because it's still not really possible to very accurately predict the responses that different people will get. A lot of research that I'm involved in and other people are involved in are trying to figure out patterns of response to know. But at the moment, your own journey will be your own journey.
And that's probably going to tell you more about your tumour, how you react to certain things. I remember with the seizure control, we were almost guessing. It's kind of like the way my neurologist put it to me was, we're putting a cocktail together and we've got to work out how much of this and what doesn't work. And unfortunately, that is more trial and error than we can guarantee you're not going to have another seizure ever again with this.
Absolutely. There's a lot of titration, trial and error, adjusting and optimizing for the patients. There's a lot of personalized care, actually, in that sense, that we do. Also for steroid medication as well. We often use steroids to reduce brain swelling. Again, we try and titrate it very carefully, so you're just on the right level to give you the relief of symptoms without causing the side effects. So there's a lot of that's needed, a lot of personal care needed. Again, contrasting to other cancers, I think that there's more acute initial work needed at the very beginning.
I was going to poke the bear a little bit and ask you about that. That initial work, it's something that I'm very passionate about. I know a lot of other brain tumours patients are. What do we need to do more of? You mentioned that 180 odd tumours.
There's a lot,
And there's the conversation of genomics, and how do we get that kind of...
It's a multi-pronged thing. We just need more awareness, more funding, which again, a lot of the main charities in the UK are fighting for, and I'm so thankful they are, because we need that funding. And there's different segments that, again, the Tessa Jowell initiative has identified when we look at centres of excellence. So basic research is needed, understanding what are these cancers exactly, because still we don't fully understand them. Which treatments work and how, to what are the chinks in the armour of these tumours, so how can we treat them properly. Advances in surgery, so we haven't had any strong advances in surgery for a very long time, so that's my area, where we're looking for novel ways of profiling tumours during surgery, and using intelligent AI-driven technologies. The ideal is that every patient in some way is involved in some kind of a trial to advance our knowledge further. And also just knowing what are the trials out there, because at the minute there's no easy to access database or proactive system for people to use. And again, a lot of work is being done at the moment to create that or allow access to that data. But as well as that, and in my own centre, for example, the way we organise care is very much doctor-driven or healthcare system-driven for healthcare efficiency. But in our centre recently, we realised there's a lot of work needed around the psychological element, around the psychological support, the rehabilitation support, which we've really focused on. And those are kind of black holes, really, that need to be filled. So that multi-pronged approach to help the holistic care of the patient. Because from our conversation, you've seen how personalised the care needs to be.
I mean, I always get this, when I break it down really simply, you've got the kind of let's find a cure side of it, which is the research and the labs and that kind of stuff. And you've got the we're in it. How do we make this as good as possible? However short this life or long this life may be, how do we make it as good as possible? And they're two very different elements. And like you said there, just bringing the psychology element into it is a huge, huge thing for people that are going through that process right now. I can say even after coming out of radio and chemo, how much I need that support now more than almost when I was going through it. So it's really I'm pleased to hear you say that, to understand that part of our side of the coin almost.
It's critical. And as you say, there's this like two big things we're pushing for. The first is trying to find a cure.
Yeah.
And that requires a lot of energy and a mindset where we're going to defeat this.
Yeah.
But also the realism of where we are now, where we don't have a cure right now. So actually, what are we going to do for quality of life right now?
Right now.
And have the tangible stuff that we can deliver straight away. In a way, the low-hanging fruit.
Yeah.
So we're talking about psychological support.
It's a really good way of putting it. Yeah.
Not just for the families, but for the patients, but for the families as well. I think that's critical. Picking up on what kind of support is needed and when. And I think brain cancer is one of those unique things where you've got both of these elements. You've got the support right now, quality of life, and also we don't have a cure, so we need to really find a cure. And none of us knows when it's going to happen or how it's going to happen. It's an uncharted future. But we're doing our very best to advance along that way.
Absolutely.
But I still feel it's underfunded. There's not enough attention given to brain cancer, and it's a relatively rare cancer, and yet it's not. Yeah, it's the one. It kills more people under 40 than any other type of cancer. So the impact is unbelievable. It's such a strange thing, isn't it? When you look at it that way. Yeah.
Yeah. No, I completely agree with you. It doesn't make any sense. The facts and the figures and the numbers, to me, make no sense how, it equates to such a small portion, like a slither, when people put pie charts in my face, and you can't even see the line of funding that gets allocated here. So it is while you do your thing in the surgery, it is also a now thing of, I've almost... sounds really morbid, but it's not meant to. I've almost accepted that it's going to take time to find this cure in my lifetime, in my journey. So I need to put my foot forward in supporting the people that are here now, while someone else is battering the door down of a lab trying to find that cure.
Cool. But finding the cure is something which I wanted to talk about as well, because it's really weird in that maybe it will be a gradual process.
Yeah.
Okay, that will take time and there'll be incremental changes. Maybe. Or maybe there'll be one massive advancement, a bit like the way AI's come out of nowhere and is revolutionizing. Maybe there will be a revolution of some sort. We just don't know.
Yeah.
And when I've looked at scientific advances kind of over the century, they don't happen gradually. They don't happen in a planned way. They happen in sudden quantum leaps, which you would never have predicted.
Yeah.
And it's about having a prepared mind. So when weird things happen, you're able to connect the dots and realize, hang on a minute, this is what's happening here. So it's just, and that's where I think raising awareness, having enough prepared minds there within the scientific community and within the non-scientific community, so that when something arises, we can harness it for a cure. That's a fascinating thing about when it comes to finding a cure for this. And that's what draws a lot of people to it, actually, doctors and scientists to this as well, is that there's a contribution to be made. And there's an excitement about how we're going to do it. Whereas other cancers, we've kind of already I wouldn't say we've figured it out completely, but we kind of know what's happening.
You've just backed up the argument for just give us more funding, because the funding that's gone into a lot of these other areas has yielded development in these patients. So we were talking about practical pathways. What are the options that brain tumor patients have right now? If they were to go in and sit on your chair now and we're having this conversation, I kind of know the soft answer to it, but what are the options that patients have right now?
So the most common options would be some form of surgery if it's deemed safe to do by an MDT and by the neurosurgeon, where physically some of the tumour, as much as possible to be safe, is removed.
Okay.
So that's kind of the start of treatment, because we're starting to remove this bad thing from the brain, and the treatment has started, but it's often not enough. And what we need.
When you say not enough, are you talking like a percentage-wise of the tumour?
Percentage-wise. So there's a lot of work being done as to how can we increase the amount of tumour being removed. The big issue is knowing what is tumor and what is not tumor. Sometimes
Right.
it's very difficult because brain and tumor tissue look very, very similar sometimes,
Okay.
particularly towards the end of an operation where you're at the edge. So maximizing how much we can take out is a big thing. So it's a focus of a lot of the research that I do, a lot of the work
Right.
that I do.
Okay.
And inevitably you will leave some tumor behind because you can't remove it all. There'll be microscopic cells beyond where you've done your surgery where it would be too dangerous to cut into that part
Yeah.
of the brain.
Yeah.
And they go beyond where you did your surgery. So how do you target that? That's where the next steps of treatment come in. After you've recovered from the surgery, which hopefully takes between 10 to 14 days physically
Okay.
in terms of the healing, then we can start some form of, depending on the diagnosis, of course,
Mm.
but your
Yeah.
oncologist may decide to give chemotherapy and or radiotherapy, but there are a lot of variables in that decision. The chemotherapy, if decided, is often a tablet form,
Yep.
which you take every day for several weeks, for many weeks. During that time, you will also be given radiotherapy daily, Monday to Friday, in order to try and target those cells that were beyond where the surgery was done. And the aim is to slow down the tumor as much as
Right.
possible, but it is not possible to cure certain types of tumor. So that's a general framework.
Okay.
And patients may get various bits of it or all of it, depending on what the doctors feel is right
Right.
for a particular patient and the particular diagnosis.
So we're using this almost like I'll put it in my my terms. We're not fighting back as such. We are defending almost. Does that
yeah.
does that with a little bit of fight in there, but kind of holding our ground almost.
We're trying to hold our ground. Yeah, we're trying to hold our ground to give good quality of life
Yeah.
for the patient and their family, and trying to doing our best to try and keep things at bay is the best way I can put it.
Okay. Okay.
Yeah.
But so it's those kind of three options that are main in that patients are open to in this country. So either surgery followed up by or radiotherapy and chemotherapy.
Yeah.
Okay.
So those are the main options, and that's the gold standard for certain types of tumor, kind of worldwide. And in the NHS, that is exactly the kind of care that you will get for aggressive forms of brain cancer.
Right.
If the doctors feel fit, there are a lot of provisos there because it depends on how healthy you are, depends on the exact diagnosis that you have, and other things as well. But that's a general framework.
Every cancer has its own kind of pathway in that sense, and I think it's quite good for patients to understand and even families to understand what is the kind of. I feel it's frustrating hearing that because we are limited to those pathways at this moment in time, and that's what we want more, and that's what we want the fundraising for, to open up more pathways. But I think it's important for people to know and understand what you can and can't do, especially here in the UK. What is options? What are the options available?
Mm-hmm. Absolutely.
I just wanted to come back to something you said before about being motivated in this kind of area and this field of work, and seeing various different patients and how much that has impacted your own life. Give me hope. What can we expect to see? What are the developments we're making right now in the area of brain tumors and the research that's going into it? And what's the hope for the future for someone like myself?
There is one thing I can say is there's a lot of interest and a lot of work going into using all of the technologies and techniques in our armamentarium to try and improve the prognosis with people with brain cancer. There's a lot of work being done with the Tessa Jowell Therapeutics Accelerator that we've seen, where we advise, which I'm part of, where we advise on academic and commercial companies who may have solutions that could be brought to bear for brain cancer, where we're able to see these technologies and that they're truly exciting. There's a lot of technologies coming in which are electronic, which are AI driven, as well as purely biological driven as well.
Right.
And the hope is through advising connecting these inventors and these technologies to a good ecosystem, we can catalyze the development of therapeutics for brain cancer.
Right.
Actual things that will change outcomes, things that will fight cancer.
That's what I want to hear. Yeah.
So, that's exactly what we're working on. And there are many, many academic institutions and companies rising to that challenge that want to do this. I'm hopeful something will happen through this. And
because, yeah, like you say there, I'm really glad that you mentioned the academics and the people that are already there responsible for, I say, popping out all these pills, because in my mind, it feels like there is something that's there if people are willing to open and let the research be done on the stuff that already exists.
I think if we give people the space to imagine creative solutions, that's what we need. We need blue sky, out of the box thinking.
Yeah.
For a complex, unsolvable problem, which is brain cancer.
Yeah.
And the thing which I've sitting on the committees and seeing all these applications, I find it amazing, the ingenuity of the human brain. That some of the techniques where there are technology to try and lure brain cancer cells to a particular location to destroy them, technologies using electronic sensors to try and detect and treat cancers. There's a lot, and I'm hopeful that one of these approaches or a combination of them may work if guided properly by the community. That's
kind of like, I think that's what the community are shouting out for. Just give these guys the opportunity to work with what we don't have and what we have, because there is so much that we already have there. Just give people, one corporate company or one lab the opportunity to test all that while the other one gets on with doing something. It's just that kind of proactiveness of what's going on in the lab coming to us, rather than we have a breakthrough over here and we found out about X, Y, and Z, but it really doesn't equate to anything in the here, in the present, in the now to treat brain tumor patients.
The adoption of this technology is a big issue, and that's where there's a lot of work we can do in the NHS, and also as people that advocate for our patients. But bringing those discoveries, discovering it is one thing, but making a treatment that will save people is a very, very difficult thing. It's a very different thing. And but the thing is, what do we do with difficult problems, right? We all come together and we make it happen. And that's what we need to do as a community in the UK. Say, okay, let's come together. Let's advise these inventors or these academics or whoever's coming up with the solution. Let's get it into practice in the safest way, or answer these important questions as a group, and not leave it to individuals to fumble along in a dark room making mistakes. But let's streamline where we're going. And the key thing is to make sure these things work. And if they don't work, we find out quickly, and we're able to learn and then move on to another technology or technique, or modify what's existing so it can work. So I'm very hopeful with that kind of approach, we can solve these issues. So, if we can make it to the moon, if we can think about going to Mars and solve all of these very difficult issues, I'm hopeful. I'm hopeful in the kind of the resourcefulness of the human brain.
Yeah,
I think. And the strange thing is, these tumours are arising in the brain as well, and the same brains are trying to solve it. So that's the most weird thing about brain cancer. But I'm hopeful that kind of ingenuity will produce some kind of benefit soon. And I just love seeing all the attention at the minute that we're beginning to get, and hopefully we'll get in the future. The other element to this as well is that's the exciting technology side. And developing new technologies. The other element is looking at our services and making sure the services that we offer are to a high enough standard everywhere. And that's very different.
That's a whole different challenge, yeah.
And that's something, again, which I think we need a lot of work on. And the work is started with the Tessa Jowell Centres of Excellence kind of a mission and support. But that really shines a light on areas that need improvement, but more so gives the toolkit to different NHS trusts to implement and improve. And the issue here is that things will become stagnant very quickly. So in a high-pressured system, people will tend to go to the lowest common denominator and just become stable. And you need a bit of agitation by, if you see what I mean, to say, no, let's up the game and let's up the game together.
Let's shake it.
Yeah.
And but shake it together. It's
Yeah.
like collaboration, I feel, is such a big.
That's the key thing. It's not competition. It's a collaborative
It isn't.
improvement. So look, guys, we can do it. It's positive rather than negative. And that's the thing that I think is happening. It makes me hopeful. And I think it'll get even better as time goes on. So yeah, that's the key thing, I think. So if we get new inventions or new treatments and then bring them to clinical use, that's amazing. And if the current infrastructure is strengthened for our patients and made even better, but not only that, but it's constantly being made better, then I think you'll have a much better world for people with brain tumours in the future. So I am very optimistic, given all of this energy that I can see.
We're going to keep bringing that energy. Trust me.
That's what we need.
Thank you so much for your time today. I'm not actually sure what I was expecting out of this conversation, but it's been enlightening to me in a whole different way. It's nice to know you guys care. I know it sounds really silly and I don't want it to sound insulting, but you're on that journey with us and we trust you so much to help us and guide us through that journey. So thank you for sharing your own emotions. And I know you've been very honest with us in that, and it means a lot. We appreciate your time.
Well, thank you, Sam. It's been quite a personal thing for me, so thank you for giving me the time to reflect, because clinical life is so busy.
Yeah,
you don't often get the chance to talk and reflect of the difficult things we do. And I'm there for my patients. I'm there for everybody, and that's why people like me and all the other surgeons that you meet. This is why we do our job.
Thank you.
So
and thank you for that. I really appreciate it.
Thanks, Sam.
Cheers.